We're tremendously thankful for the partnership we have with the Grace and for the care they provide for patients in the community. This also gives us an opportunity to invite a speaker from throughout the world, and we're tremendously privileged to have Dr. Stephen Pantilat join us today. Dr. Pantilat is a graduate of UCLA, where he was Phi Beta Kappa, and then went on to UCSF for medical school, where he was AOA, and he has stayed on throughout as intern, resident, chief resident, a Robert Wood Johnson Fellow, and after a brief stint during that fellowship, it seems, working in the emergency department, joined the Department of Medicine, where he has stayed throughout his illustrious career. He is professor of medicine at the University of California, San Francisco, and the Kates-Burnard and Hellman Distinguished Professor in Palliative Care. He's the founding director of the UCSF Palliative Care Program that received a Circle of Life recognition Circle of Life Award in recognition of innovation from the American Hospital Association 2007. He's also director of the Palliative Care Quality Network, a collaboration of over 85 palliative care teams focusing on improving the quality of care for seriously ill patients. He's internationally recognized as an expert in both hospital medicine and palliative care, and has published over 90 peer-reviewed scientific papers, authored 24 book chapters, and co-edited 2 books. More recently, he's distilled a career of 27 years of experience for a book in a book for the public entitled Life After the Diagnosis, Expert Advice on Living Well with Serious Illness for Patients and Caregivers. And in fact, it's very kind that there are copies of this book available at the back free of charge, and if there's time, Dr. Pantilat can even sign that for you. That was published just this year. He's a very good citizen nationally as well as locally at UCSF. He's served on the editorial boards for the Journal of Palliative Care and the Journal of Hospital Medicine. He's served as the president of the Society of Hospital Medicine, and he's been elected as a Master of Hospital Medicine by the Society of Hospital Medicine. He's served as a Fulbright Scholar, studying palliative care in Australia, and a Robert Wood Johnson Clinical Scholar at UCSF, as well as a faculty scholar on the project Death in America. He's received a number of awards, including the James Irvine Foundation Leadership Award in recognition of his work to improve the lives of Californians. He received the Rita E. Hellman Award from the California Hospital Association in recognition of his work to improve the quality of palliative care. He has been listed as best doctor locally in San Francisco, as well as a top doctor for cancer by Newsweek magazine. And perhaps more importantly, he's received 5 teaching awards from students at the medical school at UCSF. So it's really an honor for us to have Dr. Pantilat speak with us today. Again, I want to thank A Grace for their partnership. Today, he is providing grand rounds entitled In Search of a Good Death, Living Well with Serious Illness. Please join me in welcoming Dr. Pantilat.
Thank you so much for that very warm introduction. It's really a pleasure to be here with you this morning. I'm going to start with some good news and some bad news. So let's start with the good news first. The good news is that there's never been a better time to be alive if what you want is to be alive. Which is to say that after 30,000 years of being really flat, human lifespan has increased dramatically in the last 100 years. So in the year 1950 in the United States, we lived on average to be, in the year 1900 in the United States, we lived on average to be 50 years old. That was the average lifespan. And today in the United States, we live to be about 80. So in 100 years, a little over 100 years, tremendous increase in lifespan. And that's really wonderful news. That's in part due to good medical care. It's due to good public health, clean water, vaccines. So that's great news. So what's the bad news? Well, the bad news is that over the same time period, the death rate has remained remarkably stable at exactly 100%. That's a challenge for us as individuals, as healthcare providers, just as human beings. that we live longer, but we all die. But you knew that already. The other bad news in here is that while we live longer, most of us will live longer with serious illness. Maybe years, maybe decades with serious illness. And that creates really special challenges for how can we live well in the setting of serious illness. Serious illness like cancer, heart failure, dementia, Parkinson's disease, emphysema. The answer is that we can live well in that setting, but only if we take steps in how we think about that and how we think about it as clinicians as well as family members, loved ones, and people who will become potentially ill one day. And part of the challenge is what we say and do as individuals, as clinicians. And so let me share a story with you that highlights that. So this happened a few years ago when I was on the Palliative Care Service, and one morning I came to work, and our social worker, Jane, said, Steve, I got a call from a nurse on the bone marrow transplant unit, and she has a patient. Thank you. She has a patient who's been in the hospital for a month. She's a 42-year-old woman with end-stage leukemia. She's been here for a month. And just this morning, her husband said that they'd like to get a palliative care consult. And the nurse didn't know what to do, so she called me, hoping I could tell you, and you would call the attending, and then we'd get a consult. Because that's kind of how it goes. Has to be an attending physician asking for a consult. And I said, sure, that's fine. I know Bill. He's on service. I'll give him a call. So I called Bill, my colleague, and I said, hey, Bill, Steve Pantilat. He said, hey, Steve, how you doing? I said, oh, I'm good, thanks, Bill. How are you? Good. I said, hey, Bill, I heard about your patient, Mrs. Smith. He says, oh, yeah, Mrs. Smith. It sounds like she's not doing very well. He says, no, she's not. I said, oh, I'm really sorry to hear that. I heard from our social worker that Mrs. Smith's husband had asked the nurse for a palliative care consult this morning. I just want to say we'd be happy to come see her. He said, oh, Steve, thank you so much. But I'll be honest, she's not ready for palliative care. So, well, it sounds like she's pretty sick. She's been in the hospital for a while. Her husband wanted a consult. He said, yeah, I know, but, I have to say, she's just not ready. I said, well, okay, Bill. If you think we can be helpful at some point, we'd be happy to come see her. I said, okay, thanks. Well, Mrs. Smith died that afternoon. It really got me thinking, what's going on there that I could call my colleague on a patient who's been in the hospital with end-stage leukemia for a month, and the answer I get is she's not ready for palliative care on the day that she died. And it got me thinking, if you're not ready for palliative care on the day that you died, when are you ready for palliative care? And I realized that if we parse out that sentence, we can learn a lot. So let's do that first. So let's go to the very first word, she. She's not ready for palliative care. Who in this story is actually not ready for palliative care? Bill. Bill is not ready. I think we could argue that Mrs. Smith was ready for palliative care that day, certainly. She was probably ready for palliative care on the day that she got admitted to the hospital. We could argue she was ready for palliative care on the day of diagnosis. Certainly there are studies now, a randomized trial published in JAMA just this year, that showed that palliative care consultation for people undergoing curative intent stem cell transplant improved quality of life, not only during the time that they were in the hospital, but weeks later. So there's good evidence for palliative care in that setting. Now, we didn't have that study a few years ago, but I think we could argue that. So who wasn't ready? Bill wasn't ready. So why is Bill not ready? Well, I think there's a few things going on that's instructive for us. One, I think still we're in a situation where many people misunderstand about palliative care and think that it's about end of life. I guess if there's one message I wanted to leave with you today, it would be that palliative care is for people with serious illness, and it's not end-of-life care. We are good at doing that as well and helping people at the end of life. But that is fundamentally not what we're about. And I'll share a definition with you in a moment that I like to use that really makes that point. that's one challenge, is a misunderstanding of what palliative care is. Although it turns out that even if you think palliative care is end-of-life care, it would have been appropriate for Mrs. Smith that morning. So what else is going on? The other thing that's going on is that if you think palliative care is really end-of-life care, then if you bring it up to Mrs. Smith, right, if you say, I'm going to ask palliative care to come see the patient, then she thinks, maybe you think she's dying and that she's going to lose hope. I think there's a concern that when we call palliative care that maybe somehow the patient's going to lose hope. Because there's just a misunderstanding of what it's all about. And I see this a lot, where someone will say, yeah, I think I'll get a consult, but the way they ask the patient sort of infers this kind of bad news. Would it be okay if we call the palliative care team to come see you? I don't think that's how we ask for a cardiology consult. I mean, no offense, but it'd be all right if the cardiologist, I have a heart, sure, that would be fine. Now, it's not that I don't understand that palliative care may have a different implication about serious illness, but if the communication is around would it be okay? Well, why wouldn't it be okay? I think the way we talk about it as clinicians is really important. I have colleagues in palliative care. You have a serious illness. I'd really like them to come help take care of you. That's what I'd like, because I think that's the best care that you can get. And I want their help to help me take care of you. I think that's a very different message than would it be okay. So there's this issue of hope and whether it will destroy hope. And we'll talk more about hope in a little bit. I think hope is a really important issue. My quick take-home point for you is that we don't take away hope by talking about what's really going on. And I think in this situation you would not take away hope from Mrs. Smith or from her husband. What I've also come to appreciate over time is that part of what's going on here, at least, is grief. Which is to say, I think that Bill is feeling really sad about how Mrs. Smith is doing. He's been taking care of her for years. He gave her a bone marrow transplant, and she is not doing well. And he's experiencing grief and loss over the fact that she's not doing well. And then it becomes very hard to face the fact that your patient isn't doing well. And in fact that she is dying. And in some ways, admitting that it's time for palliative care is admitting to yourself that your patient is not doing well and dealing with grief. And I've come to really appreciate the issue of grief that each of us feels when our patients don't do well. And as a palliative care consultant, I see part of my role as really addressing that grief and giving it a name. Saying, that's a really sad case. I'm really sorry about how Mrs. Smith is doing. And realizing that each of us, that all of us, care for our patients out of love. And we love our patients, and we want to do well by them. The challenge, of course, is if you only have one way to love somebody, that may not be the way they need to be loved. Chemotherapy may not be the way to love somebody. Surgery may not be how they need to be loved that day. So one of my colleagues, another one of our bone marrow transplant docs, called me one day and she said, "Oh, Steve, you're on call. That's great. I have a patient I'm admitting to the hospital with neutropenic fever. I was hoping you could see her." I said, "I'd be happy to see her. Thank you." I said, "Steve, I've been following this patient for 7 years, and I love her like my sister." I thought, I believe that. And can you imagine what that's like when your sister is dying? And how painful that is. I thought, wow, that's how she feels. That's really profound. Then she went on to say, "So Steve, do a really good job this time." I thought, okay, this time we'll do a good job. As opposed to all the other times when we just called it in. Okay, so the first word, who's not ready? I think we are not ready. And we have to be ready. Our patients will come. They will accept it. When I go into a room as a palliative care physician and I talk to patients about what we do, they are happy that we are there. I would say about half now have some inkling of what I do and half do not know at all. And that's up from probably 10% who knew what I was doing maybe 10 years ago. So I think that's gotten a lot better. I think it's more in the public. It's more in the lay press. You hear about palliative care. But when I explain what I do, they're very interested. So it really begs the question of what is palliative care? But what is it that she's not ready for? And so let me share with you the definition that I like. This is the definition that I'm now using for palliative care. There are longer ones. I think the Center to Advance Palliative Care has a wonderful definition because it has a lot of language that we can use, extra layer of support that's really helpful in talking with patients, but it's too long. So I like this short, pithy definition. Palliative care is medical care focused on improving quality of life for people with serious illness. Fundamentally, that is what we are trying to do. Two things that are important here. One, serious illness. So what is serious illness? We all know what it is. Heart failure, cancer, dementia, stroke, cirrhosis, emphysema, COPD. Right? That is what serious illness is. The reason that palliative care gets involved with patients and why patients need it is because they have serious illness. And I like that language because patients understand it. They understand what a serious illness is and that if they're sick this way, they get it. Number one. Number two, it's about quality of life. How do we help our patients achieve the best possible quality of life? That's our goal. You might argue that's the goal of medicine, to help people live well and have a good quality of life. But I would argue that in palliative care, the focus really is on understanding what gives people's life quality and really trying to help them pursue that. Abraham Lincoln said it's not the years in your life, but the life in your years that matters. And whether life is measured in years, or sometimes in months, or weeks, or even days, the question for us is how do we help our patients really have the best possible quality of life? And that's what we focus on. But then the last question is, what does it mean to be ready? When are you ready for palliative care? I guess the other thing I will say just about palliative care and about being ready for it is that when I think of all the things that can happen to you at UCSF Medical Center, palliative care is about the nicest thing that can happen to you. No offense. We're a team. We're nice people. Not that other people aren't nice, but we are nice. We come to your room, we sit down, and we try to understand how you're feeling. And we want to help you feel better. We don't poke and we don't prod and we don't have a lot of procedures that we do. And we're really trying to focus on you as an individual and your family member and how you feel better. So I think, wow, everybody should want palliative care. So what does it mean to be ready? So this is my version of this figure. If you've ever heard it talk about palliative care, I assume you've seen some figure like this one. There are many versions out there. This one is mine. It tells us that at time 0, when a patient is diagnosed with a serious illness, the main focus will be on cure, appropriately. There's so many things we can do to help people materially feel better and treat their underlying illness, and we should do that. I mean, that's really the beauty of modern medicine with new treatments all the time. I mean, that's really wonderful. But there's a role for palliative care even at the moment of diagnosis. I think understanding that and understanding the issues that patients have and the questions they have really at diagnosis. Let me give you an example. My patient Sam, he was 89 years old. He was a retired high school biology teacher living in a row house in San Francisco with his wife, who was 90. They went dancing 3 times a week. Sam drove. So they were doing really well and had a really lovely life. And one morning his wife calls and says, Dr. Pantilat, I can't get Sam out of bed. His hip is really hurting him, and I don't know what to do. And I said, well, do not try. Just call the paramedics and bring him to the ER, and let's see what's going on. Maybe something happened. Maybe he has a fracture. So sure enough, they do an X-ray, no fracture. So they do a CT scan, because maybe there's a small one. And there's no fracture. But they get a few cuts through his liver, and it shows that there are 2 masses suspicious for cancer in his liver. Completely unexpected. The pain got better. He was able to go home. They set him up for a biopsy, an ultrasound-guided biopsy, that showed that, in fact, he had colon cancer that had spread to the liver. Completely unexpected, unrelated to his hip pain. And so he came to my office with his wife and his daughter, and I had to share with him this really terrible news. "No, Sam, I'm really sorry to have to tell you this, but the biopsy showed that you have cancer, colon cancer, that has spread to the liver." And right away he had two questions for me. Can you imagine what he asked right away? How long do I have? Am I going to die? Right away. That's very common. But those are the questions people have in their minds. They think they're going to die when we give them a diagnosis like that. I would submit to you that those are palliative care questions. Prognosis, end of life, which is not to say that you have to be a palliative care expert to respond to those questions. But the content really is palliative care. It's something that we all have to be prepared to do. All of us, doctors, nurses, social workers, chaplains, if patients turn to us and ask those questions. And it's important for us to know that's what's on the patient's mind. It was really interesting that as we started talking, it became clear that Sam thought he had 2 or 3 weeks to live after this diagnosis. I'm not sure where he got that information, but I thought he had something on the order of a year or so, which is in fact what happened. He lived about 10 months. And then we talked about, well, what are we going to do about this? And I sent him to an oncologist, and he got chemotherapy. So you can see there how the bar goes up here, more focus on cure. He got very sick from his chemotherapy, landed in the hospital with complications. And what this shows us over time is that either because treatments are no longer available, we do sometimes not have treatments for the underlying illness, or because the patient no longer wants them, more of the focus can be on palliative care rather than on cure. It also shows us that even very close to the end of life, there is still a role for curative intent treatment. Patients with heart failure, for example, patients with Parkinson's disease are often still taking the medication for their underlying illness very late in life. In fact, until the point where they can no longer take the medicines. They can't swallow them because they're helpful in helping you feel better, keeping you out of the hospital, and helping you live longer. I show a couple other things here. The hospice line here in the last 6 months of life, just to remind us the importance of hospice services. You do need a 6-month prognosis, but the reality in the United States is that while 45% of Americans who die make use of hospice services, the median length of stay in hospice is 18 days. So half of people spend 18 days or less in hospice. 35% spend a week or less. And 15% only spend 3 days in hospice. The benefits of hospice accrue, the benefits to family members and to patients accrue with longer hospice stays, at least a week. And what I hear from patients and families is, I wish I had been referred sooner. Now, there are many reasons why that doesn't happen, and I'm happy to talk about that more. But just to remind us all, here's a really helpful, important service, good for patients and good for their family members. And we should think about it sooner. And then finally, just the green part here, just to remind us that we as clinicians play a role in caring for family members in bereavement. What an important experience that is, and the role that we play. Our palliative care service sends cards to all family members. Hospices will remember at a year and send a card. And it shows here that while the acute pain of loss does get better, generally over 6 months, it never goes away. And you'll hear people say, oh, don't worry, you'll get over it. But you never get over the loss of someone that you love. It does get better, it becomes less painful, but it's important for us to acknowledge that. I remember one of my mentors said, when you see a patient in your clinic who's had a loss, how do you address it? And I said, I don't know. That's a good question. One thing I learned was to ask, what are you thinking about your wife today? What are you thinking about your son? Recognizing that we think about them every single day, the people we lose. And if we ask, what are you thinking about, it's an open door for them to tell us. So that's the challenge of what we say. And I think in there is a lot of lessons for us about what we can do better as clinicians to really help our patients live well with serious illness. I think the other challenge is that there are misconceptions, not just in the world of medicine, but there are misconceptions in our society about serious illness. And I want to address a few of those, some of these myths that I write about in my book, but that I've also experienced in talking with patients and families that I think will also help shed some light on how we might help them better through serious illness. And the first, and then I just want to say that what I tell patients and families as well is my goal is to help you live as well as possible for as long as possible. That's the other language that I use. People really like that. My job is to help you live as well as possible for as long as possible. Yeah, you can stay in my room and I want to talk with you. You don't have to choose between quality and quantity of life. And we often give people this sense of you have to choose. Right? Do you want quantity of life or quantity of life? Do you want to live long or do you want to live well? And the assumption here is if you want quantity of life, you have to accept all of our treatments. Have surgery, undergo a valve replacement, have more chemotherapy, enroll in a clinical trial. Right? That's how you live long. End up in the ICU, go start dialysis. Or you might say, well, those things are pretty uncomfortable, so if you want quality of life, don't do all those things. Forget about those and just focus on your quality of life. And that is really a false choice that we give people. It's false because many of the treatments that we have actually will help you have a better quality of life. And it's false because making that choice is actually not the right choice. And it suggests that the treatments always make you uncomfortable and that quality has to be associated with not living quite as long. I think the reality is that you can have both. And what we're seeing increasingly is that for people with serious illness, palliative care helps you have both. And if there's one study that I think you should know about palliative care, it's a study that was done by Jennifer Temmel and colleagues at Massachusetts General Hospital. It was a randomized trial of palliative care for people with lung cancer. It was published in the New England Journal of Medicine in 2010. They enrolled 151 people with a new diagnosis of metastatic lung cancer. So incurable lung cancer with a median survival of 9 months. All patients received standard chemotherapy at Massachusetts General Hospital at Harvard. I like to say, and apparently that's pretty good care there at Harvard. I always like to say it's not UCSF, but apparently Harvard is pretty good. Half the people were then randomly assigned to receive palliative care in addition to their cancer care. And then they followed them forward, and what did they find? Well, what they found was that everything good we want to have happen to patients happened to the ones who got palliative care. Which is to say, they had a better quality of life, they had less pain and shortness of breath, they had a better mood, they were less likely to be depressed. They were less likely to get invasive care at the end of life, meaning in the ICU, chemotherapy in the last month. Better health for their loved ones, not necessarily in this study, but in other studies. Increased satisfaction with care. And in palliative care studies, generally, patients live just as long, if not longer. In this study by Jennifer Temmel and colleagues, the patients who received palliative care lived longer by 3 months. Longer. As good or better than chemotherapy. In fact, if this was a chemotherapy trial, everybody would get this drug. Right? If you had invested in that company, in fact, they would give it for heart failure, and they'd give it for dementia. Right? A drug that helps you live 3 months longer. And importantly, no side effects. True. This is true, actually. The American Society of Clinical Oncology, in fact, has a clinical guideline that recommends palliative care, specialty palliative care within 6 weeks of diagnosis with metastatic cancer. And in the guideline, it says there's never been a study that has shown adverse effects from palliative care. Think about all the treatments we give and the side effects that we see. It's saying a lot that there are not adverse side effects. In some ways, I wish it was a drug, because then everybody could get it and could get it very easily. There's a whole system in our country for distributing those treatments and making it very easy for people to get them, for us to pay for them. But it's not that. It's actually a lot more complicated than that. Palliative care is a team. Doctor, nurse, social worker, chaplain who provide care to patients over time. And it's just harder. It's harder to set up, and it's more complex and more nuanced to provide, and yet just as important. And there are other studies now that show the same thing. If you're really interested in reading, I think the paper here by Dio Caballeros from Pittsburgh is a wonderful review of the literature, if you'd like to see a review, in addition to the study by Jennifer Temmel and colleagues. So who needs palliative care? Well, I talked about serious illness, and I think that's certainly true. I think the other way we think about who needs palliative care are people who have high utilization. Increasing utilization is a poor prognostic sign. Coming to the ER a lot, getting admitted to the hospital a lot, beginning to use more services. And then function. Probably the single best predictor of prognosis and of your need for palliative care is your function. There are many ways to measure it with the Karnofsky score, the ECOG, the Palliative Performance Scale score, which is something we measure on every patient. But thinking about what their function is very important for patients. It's one of the things that we don't see in the electronic health record. Among all the reams of data, we have lots of lab data, we have lots of physiologic data. We do not have data on function. One of my colleagues, Dana Lusbader, who has a home-based palliative care program on the East Coast, says the way they look for function is they look for a prescription for a cane. And then the cane goes to a walker, and the walker goes to a wheelchair, and then it's a bedside commode. And that's one way to look for function. Although what we really should be doing is measuring function in people with serious illness on a routine basis. And hopefully that will change, and we'll have that data available so that we can target interventions more closely to our patients. So here are the serious illnesses. I think this is not a hard list to come up with. I think all of us could generate this list pretty quickly. But just to remember, these are the diagnoses that matter. And then another way to think about it is to ask yourself this question, call it the surprise question. Would I be surprised if this patient died in the next year? And if the answer to that question is no, I wouldn't be surprised, that is definitely someone who needs palliative care. It turns out we're pretty good at using this question for identifying people who need palliative care. We are not good at using this question to predict who's going to die. So that study's been done by Josh Lakin, asked primary care doctors this question, and they were not good at figuring out who was going to die. But that's not what this question is about. It really is about who is sick enough to die. And what it tells us is this is not prognosis-based. Even though hospice requires a 6-month prognosis, that is not the basis of determining whether someone needs palliative care. It really is about serious illness, function, and the needs they have. So the other challenge that we have in our society, another myth, is that somehow talking about what's really going on is going to destroy hope. And I would submit to you that talking about what's really going on does not destroy hope. Hope is really important. And I understand that we worry about taking away hope because we don't want to take away hope from our patients. They come to us looking for hope and with a lot of hope that we will have treatments that will help them. And we worry that if we talk about what's really going on, the patient's going to lose hope. But I would submit to you that doesn't happen. And in fact, that talking about hope encourages it. We might ask, well, what is it that people with serious illness hope for? Well, people hope for healing even if there's not a cure. They hope for comfort in the face of suffering. And they hope for all that can still be despite the things that cannot be. What does that mean? We were taking care of a woman in the hospital. She was in her 70s. She had advanced interstitial lung disease, admitted to the hospital with an exacerbation, shortness of breath, ended up in our ICU on high-flow oxygen. And that's where she was stuck. And she was not getting better. It was at a point where there was nowhere for her to go. She couldn't leave the ICU. She was getting sicker. So one morning on rounds, we went in, and we asked her what she hoped for. I remember the ICU team, I said, let's go in and ask her what she hopes for. And I remember the ICU team was like, I don't think that's a good idea. I mean, she's not doing very well. I said, well, that's okay. Trust me on this one. We went in and we said, you look to the future, what do you hope will happen? That's the question that I like. And she said, well, my daughter's getting married, and I want to be at her wedding. Right? Well, that's really important. Tell us about that. So, well, she's getting married in the Napa Valley in 10 months. And I thought, I don't think she's going to make it. I don't think she's going to live 10 months, and I don't know how she's going to get out of our ICU to get to the Napa Valley. So I don't see it. So we talked about it as a team. Then we talked with her daughter and with the patient. And the daughter said, well, that's fine. Let's get married right here. Great. So a few days later, she came with this beautiful white wedding gown. And her fiancé came with his tuxedo. And they put a corsage on the patient's hospital gown. And the priest came, and the family, and all the doctors and nurses and respiratory therapists, and everyone was around the bed. Not a dry eye in the ICU. And it was beautiful. And she got to witness her daughter get married, which was the thing she hoped for. It would have been very easy, one, to not ask the question, and two, even if we'd asked the question, to say, I hope so too. Right? That's easy. Yeah, I hope so too. But what does that mean? The patient thinks that you think she's going to make it, when exactly the opposite is true. So we have to both have the courage to ask the question and then the courage to say what's true. And that did not destroy her hope. It actually encouraged her hope because she got to experience the thing that she hoped for. Because we asked about it and we were honest about the possibility. And if we hadn't done that, we know what happens, right? She gets so sick. When she's really sick, suddenly her daughter, it sort of occurs to everyone, I should probably try to get married, and then it's too late. When I said it was beautiful, I am not suggesting that you plan your wedding in the ICU. It's not that beautiful, but it was beautiful in that setting. And I will admit that I had this thought as I was standing in the back. I thought, how are they going to clean that wedding gown? Because it is disgusting, right? It's got C. diff and MRSA and VRE on it, and I thought, that is really gross. I did not say anything. Do not worry. I didn't let on. I said that there was a question that I really liked about hope, and I want to share with you the two questions that I like. I call them golden questions. And the reason I call them golden is because of how helpful they are. So I want to share them with you as well as something you might ask your patients. When you think about the future, what do you hope for? There's that hope word. And when you think about what lies ahead, what worries you the most? Hope and worry are opposite sides of the same coin, right? What you hope for is what you want. What you worry about are the things that you want to avoid. Right? I worry that I'm going to be a burden on my family. I worry that I won't recognize my children. I worry that I'll end up in a nursing home. I worry that I'll be in excruciating pain. Understanding what people worry about can really help us. We can reassure them about some things, and it helps us guide them away from the things they worry about. And knowing what they hope for is equally important, if not more important, because it really shows us what we can do to help them. Hope is so important that if I ask a patient what they hope for and they have nothing, I worry that they're depressed. Because hopelessness is a sign of depression, always, but particularly in serious illness. Where the other signs of depression, not sleeping well, poor appetite, right? Those can be a sign of serious illness. Do you still do the things you enjoy? Well, not so much. I'm kind of stuck in bed, and I don't really do the things I enjoy. So those signs of depression are hard to use in serious illness, but hopelessness, helplessness are still very useful. And I find that even very late in life, very close to the end of life, people still have hope. Yes, what they hope for changes, but they still have hope. So what else do people hope for? Well, here's a study done by the California Healthcare Foundation in 2011 of Californians, over 1,000 adults in California, about what are the most important issues when you think about the end of your life. Now, I will admit that Californians are different, but we're not that different. So these are relevant. Making sure my family not burdened financially by my care. Being comfortable and without pain. Being at peace spiritually. Making sure my family is not burdened by decisions about my care. These are what people think about that are important to them. This is why we practice palliative care as a team. If you look here, there's a role for every member of our team. Social work, chaplain, nurse, doctor. We have to be prepared to respond and address these issues for our patients because this is what they are thinking about and what they care about. What's interesting? Living as long as possible, endorsed only by 36% of people, which is to say it's not unimportant, it's just not the most important thing to the most people. But if you looked at our healthcare system, you might think it was the only thing that was important. It's not the only thing that's important to our patients. And just a point about how do you make sure your family is not burdened by tough decisions about your care? How do you do that? Advance directives. Right? You got to talk to them about it. Otherwise, they will be burdened by tough decisions about your care. Because we know what we do. We turn to family members and we say, what do you think your mom would want here? If the answer is, I don't know. That's a burden. I think in general, people get more care than they probably would want in the absence of explaining to their family members what they do want. Thinking about advance directives and implementing them is very important. And so we've taken some of these lessons, some of these ideas at UCSF, and have really tried to create a system of care. How do we take these ideas that we have about quality of life, about serious illness, about advanced care planning, what's important to patients, and turn it into a system of care? So I want to share with you a little bit about what we're doing at UCSF, and then a few other comments before I close. And so we've developed this vision for palliative care, which is to provide integrated, comprehensive, high-quality, interdisciplinary, person-centered palliative care in all settings of care. That's the goal we have set out for ourselves. That's what we want to achieve. There's a lot of adjectives in that definition. I understand that. But that is really what we want to do. How do we make care comprehensive? How do we make palliative care available to all patients with serious illness who need it across our healthcare system in every setting of care? The way we've done that is we've started by bringing together folks from across the campus who have an interest in palliative care and who care for people with serious illness. And this is just a partial list of all the folks that are involved in this process at UCSF. And here are some of the faces of the people. It does take a very large village to make this happen. And so we've brought people together from across the campus to really implement this idea. So I want to share with you sort of the model we've developed, the conceptual model of how we want to approach this. And it's really taking a step back and saying, we want to take a population health approach. So right now the way it works is that if you have a patient with serious illness and they get referred to our service in the clinic, in the home, in the hospital, we'll come see them. But we're just waiting. And what we know is that there are people out there who need palliative care that we are not seeing. On any day at UCSF Medical Center in our 500-bed hospital that we have 25 patients on service, I think there are another 50 at least who need specialty palliative care, but I don't know where they are and how. Well, I probably know where they are. I can guess. I just don't know how to get to them. And frankly, we're so busy that we're not really looking for them. But that's not a system that really addresses the needs of patients. So if we think about intensity of palliative care needs, and we see how they change over time, what we can say in general is that needs intensify over time. Patients have more needs, and they get more serious over time. So how are we going to address those? Well, I think the first thing that patients need is advanced care planning. It's the need that you have earliest in the illness, really from the moment of diagnosis. If you think about people with dementia, when they're first diagnosed with their cognitive impairment, they don't have a lot of palliative care needs. They may be anxious about the future, but their need really in that moment is for advanced care planning while they are still able to participate. And we see that with many illnesses at the moment of diagnosis. And so we are thinking about how do we implement advanced care planning across our system that doesn't require one doctor, one nurse to talk with one patient at a time. Because that, while it's effective, is not very efficient. And we use web-based tools like Prepare for Your Care that my colleague Rebecca Sidori has developed. Can we use the Conversation Project? Can we use ACP Decision videos developed by Angelo Volandis and his team out of Harvard? There are many ways that we might do this. Classes where people come together as a group to learn about advanced care planning. Can we do this out in the community? There's the Conversation Project, where people can do this at home. So thinking about how we do this in a more efficient way is very important. And then we have to recognize that over time, people will have more palliative care needs and that they need primary palliative care. What that is palliative care that any of us should be able to do. Any clinician should be able to do the basics of pain management, of communication about advanced care planning, provide spiritual and psychological support, or at least assessment. The good news is that we are learning how to do this. Medical schools, including here, nursing schools. It's now a required part of the undergraduate nursing curriculum to learn palliative care. This is happening. This is being integrated. And I think that's really good news about the future. But that's work that any of us should do. Just like if you think about heart failure. Most people with heart failure do not see cardiologists. They certainly don't see heart failure experts. Pretty much all of us need to know something about heart failure and how we're going to take care of it. Same thing for diabetes, high blood pressure, palliative care. We also then recognize that there's a role for consultative palliative care for people who get sicker, who have more needs, who should be referred, and what are those criteria for who should be referred, and how will we know? And then finally, recognizing that there's a time when palliative care becomes the primary focus of care for people who are in hospice or getting home palliative care. And that rather than focusing on other parts of care, palliative care becomes really the focus of their care, and we have to be able to provide that as well. For the many patients who don't qualify or who don't want hospice services, we have to think about how we're going to provide that care in the home for people who need to be at home. Increasingly, we are using telehealth to try and reach those people who may be too sick, too weak to come to see us in the clinic. So that's a model that we are working to implement. I can't tell you that we've done it at UCSF. This is a lot of work. It's a lot of people to implement the system. But we are working on various parts of it, on screening people in the hospital, beginning there, to find out who does have a palliative care need and then trying to target the service to the need that the patient has. The goal ultimately for us and for the healthcare system is to make palliative care routine and not random. Right now it's a random event. You can have two people in the ICU, beds next to each other, similar illnesses, similar needs. We're seeing one patient and not the other, and if you look at the patient, you can't figure out why one person is being seen and the other is not. That's not the system of care that really provides the best care for patients. That's not how we want to do flu shots. It's not how we do mammograms or colonoscopies. If we left it to random chance, we know that people will fall through the cracks. So that's to say we need case finding, we need screening for palliative care needs, and we need targeting of the intervention to the need. Not every person with a palliative care need needs a specialty palliative care consult. But if they need advanced care planning, we need to know in our system how are we going to get you how are we going to get you advanced care planning if that's your need. So that's the model that we're working on. So I want to finish by addressing one more myth that we have in our society. And that is the myth of the good death. And the idea is that somehow the goal is to have a good death. And I would submit to you that is not the goal. That is certainly not my goal as a palliative care doc. The goal is not to have a good death. The goal is to live a good life. That should be our goal, is to help our patients live well. And you hear a lot about the good death. You know, you've got to have a good death. There's death cafes. Anyone been to a death cafe? No? You know they have these things? Yeah, one person? Yeah. So you talk about, your death. I think about this word, the good death. And, I've seen a lot of death over my career. I've been at the bedside of many people who are dying. I've been at the bedside of many patients at the moment of death. I have seen peaceful and comfortable and dignified deaths, but I haven't seen a good one. They're all sad, and they're filled with grief and loss, even after a long period of dementia, where a family member might say, it is a blessing that she died. There's still a lot of sadness. I took care of a woman who was 102 when I met her. 102 years old, she came to the hospital. 2 weeks before coming to the hospital, she bought a new car. True. She was driving. She was driving this new car at 102, and she bought a Prius. And she was really proud. She was supporting the environment. She felt really good. So there she was having lunch with her family, and she collapsed at the dining room table. Unresponsive. Brought her to the ER. Turns out she had a huge subarachnoid hemorrhage, massive stroke, not survivable. I was called, our team was called to come see her. She was in the ICU, intubated at the time. So I walk in. There she is. All her family is there. And we started talking. I said, I'm really sorry this happened. And go, well, she had a good long life. I'm like, I think we can all agree. She had a good long life. And they said, she did not want this. So can we just stop this stuff and just let her die peacefully? I said, of course we can do that. We'll take good care of her. They said, thank you. And I thought to myself, this is about as good as it gets, right? You live to be 102. You're still driving. You're still eating. You're appreciating your family. And then you die in an instant. You don't even know you're sick. See, I think the only thing better that people tell me is I want to die in my own bed while I'm asleep. I want to die in my sleep, which I think is probably better, except for the person who wakes up in the bed next to you, which I think is a little creepy, actually. And I'm sure it happens, and you probably get over it, but it's a little weird. I thought, okay, this is the best it gets, right? This is it. This is the thing we might all hope for. And yet, this room is filled with sadness and loss and grief. So it wasn't good. The other thing is, I can't imagine that we're going to make death so good that people are going to sign up for it. Right? We got life over here, and then we got a really good death over here. I don't think people are signing up for that. And the other thing I worry about is that when I talk with my patients with serious illness, that is not what's on their mind. They're not interested in talking about that. What they're really interested in is how am I going to live well today and tomorrow and have another good day every day. So when I talk to patients with serious illness, that's my focus. I think that needs to be our focus. Yes, death can be peaceful and calm and comfortable and dignified, but we shouldn't think of it as somehow being good. And I think that language just doesn't resonate with our patients. So having said that, I do, in the last minute here, want you to just imagine for a moment the end of your life. So just imagine it for a second. What does it look like? Where are you? Who are you with? Okay. So who thought of this? Who imagined this? No one? That's amazing, right? None of us think about it. 1/3 of Americans will die in the hospital. 1/3. 25% will have a stay in the ICU at the end of life. So this happens for legitimate reasons, right? You come to the hospital like the patient I told you about. She died in an ICU. And you would say, oh, that was terrible. But I would submit that was absolutely appropriate. We didn't know what happened to her. She ended up in our ICU. But many people come to the ICU. You know that they were destined to be in the ICU and they were not going to get better. It's not where they wanted to be. That's why we need to talk about it. If you don't want that, you need to write it down so that can be respected. Otherwise, that is what happens to you. So, on this idea of quality and quantity of life and on living well, I want to read just a brief excerpt from my book about my grandmother, my Safta. My Safta used to sign birthday cards with the wish that you should live to 120. Moses lived 120 years, and a traditional birthday wish is that you should have a long life like Moses, the greatest teacher and leader of the Jewish people. But as she got older, my grandmother changed it a bit. In Hebrew, she switched just one letter, and the change in meaning was profound. Rather than writing, live to 120, she wrote, live to 100 like 20. Live long and live well. My Safta understood that a good life is even more important than a long life. She lived that saying and declined chemotherapy when she was diagnosed with lung cancer at age 93. Now, not all of us will live that long, but we can all live the essence of that saying by living well. And the challenge that we have then in medicine and in the healthcare system is how we help our patients live well in the setting of serious illness. I show this just briefly, just to remind us the role that we play at the bedside in the care of patients, that it's not about the treatments that we give them necessarily, but it's about who we are as individuals and the power of relationship with the patient, how we express our love for patients at the bedside. This was painted in 1898 and is a respectful picture of the doctor by Sir Luke Fields in honor of the physician who took care of his son, and his son died. This painting wasn't done because this doctor saved this boy's life. The doctor is doing something really important here, tending to this patient, being with this patient at a very important time. We all have the opportunity to do that, to bring our humanity to the bedside, always, but especially for people with serious illness. To remember how important that is. Often more important than the treatments we do to patients is who we are with them as they go through serious illness. So to wrap up, the title here was In Search of a Good Death, and I want to thank Rick for really pushing me on the title. I really appreciate that. In Search of the Good Death, but I would say there is no good death, so forget it. We're actually in search of a good life. But that's a totally different title for the talk and maybe not quite as intriguing. So I like the title. But really what I wanted to talk about is In Search of a Good Life. So let's screen people with serious illness for palliative care needs. Let's target interventions to meet the palliative care needs of people with serious illness. Educate all clinicians in basic palliative care so that all of us can provide palliative care to our patients. We want to establish specialty palliative care services in every setting of care, whether patients are at home, in the hospital, in the clinic, wherever they are, skilled nursing. And the goal ultimately is to live a good life, not just for our patients, but for ourselves as well. And if we can do this, if we can set up a system that really provides good care to people with serious illness, we will make care better, not just for them, but for their loved ones, and I would argue for our society as a whole. Because the way we take care of the most vulnerable, the sickest, speaks volumes about who we are as people. And ultimately, the way we care for people, the words we say, the treatments we provide, the caring that we demonstrate is what's most important. So I'm going to finish by giving you a quiz. Don't they give quizzes at Grand Rounds? Yeah, okay. I'm actually going to give you the easiest quiz you've ever had for two reasons. One, you don't have to write anything down. And two, I will not grade you. So just follow along. It makes an important point about caring. Name the 5 wealthiest people in the world. Name the last 5 Heisman Trophy winners. Name 10 people who have won the Nobel or Pulitzer Prize. Name the last half dozen Academy Award winners for Best Actor and Actress. Name the last decade's worth of World Series winners. How'd you do? Terrible, right? But the point is that none of us remembers the headliners of yesterday. But think about it. These are no second-rate achievers. These people are the best in their fields. But the applause dies, awards tarnish, achievements are forgotten. I'm going to give you another quiz. We'll see how you do on this one. List a few teachers who aided your journey through school. Name 3 friends who have helped you through difficult times. Name 5 people who have taught you something worthwhile. Think of a few people who have made you feel appreciated. Name half a dozen heroes whose stories have inspired you. Easier? The lesson. The people who make a difference in our lives are not the ones with the most money, the most credentials, or the most awards. They're the ones who care. Thank you very much. Thank you.
Dr. Pantilat, that was absolutely outstanding and truly inspirational. I'm afraid we've reached the end of our hour. We may be able to take questions here up front. I want to thank Toby Campbell and Grace for arranging this really wonderful grand round.